and only 1.5% in Thailand. This talk about 5-year anticavial therapy. And look at tenofovir therapy up to 8 years. You can see that S loss still really minimal. You see 12% that European Caucasian, but if you look among Asian, none of the Asian have S loss with 8-year tenofovir suppression therapy. So therefore, we might looking at another agent that allow us to stop antiviral agent without the high risk of reactivation. So this study from Taiwanese, they look at the antigen level at the time that they're stopping antiviral agent. You can see that if the antigen level is still greater than 200, you can see that 80% have HBV reactivation just within 3 months post-treatment discontinuation, comparing only 9% among those who have H level less than 200 at the end of treatment. And another thing is, those who have low antigen level, if even you stop, you can see cumulative higher incidence of S loss and up to almost 1/3 of the patients. Lastly, we might able to maintain response after stopping antiviral agent by using interferon additional therapy. This is a Chinese study, OSST study. They look at the patient who on long-term anticavial at least 9 to 36 months have DNA suppression below 1,000 copies per mil and have low E antigen level, and randomized to either continue anticoagulant monotherapy or switch to PEG interferon with 8-week overlap of anticavial. You can see that, I think you know the results. Those who switch to immunomodulator had a better E seroconversion, higher antigen loss. But the key factor is look at the baseline by the time that you add on or switching to interferon. If the time that you switching to interferon, the patient had the S level less than 1500, you can see that 33% achieve E seroconversion and 17% of the patient have S loss. And if you look at 12 weeks after switching to interferon, S decline to less than 200, you can see that 33% of that patient achieve S seroconversion. So this is the way that you increase S loss among who on long-term antiviral agent. My last part, I will spend a few minutes to improve certain of therapy with combination therapy, either sequential. This is the one, the sequential treatment. You can see that E positive patient achieve anticavial for 12 weeks, and then they add on PEG interferon for another 12 weeks. And follow me carefully. After adding on PEG interferon, they select only those who respond well. Those who has DNA decline and significant S decline more than half log after 12 weeks of adding interferon, continue interferon monotherapy for another 36 weeks. But those who lack of early response, they stop and switch back to monotherapy with anticavial. You see the result. You can see that the outcome is so good. Complete certain response, that means DNA below 20, seen in 60%. And E seroconversion almost 77%, and S seroconversion 20%. So mind you, did not all patients pick up those who respond with adding on interferon for 12 weeks. It even pick up some patients, but in the way that might allow us to pick up the right patient who are going to benefit with interferon adding on or switching therapy. The last part is about recent presentation, is study between Caucasians and Asians. Look at over 700 patients, 6% were E positive. You can see genotype across, because this combined European and Caucasian study. And comparing between tenofovir PEG interferon combination therapy for 48 weeks, combination therapy for 16 weeks, and followed by tenofovir for another 48 weeks, or tenofovir monotherapy and interferon monotherapy. And you can remember from this one, you can see those with interferon-based therapy, partly interferon plus tenofovir has a greater and faster decline in surface antigen and significantly faster and greater than tenofovir monotherapy. And look at the S log, you can see that tenofovir and pegnephron combination therapy had the highest S antigen loss at year and a half of therapy, up to 9%, comparing none of tenofovir achieved S loss. So this might improve the response, but we can pick up who are going to do well. We know that those who have S decline at week 12 of this combination tenofovir and peg interferon therapy. At week 12, if S decline more than 1 log, you can see 43% chance of achieving S canon. And those who have less than 1 log decline, you can see only 3% will achieve S loss. So it can provide as a stopping rule not to combine all the way for 48 weeks. At week 12, we might able to stop interferon and continue only tenofovir monotherapy. Mr. Chairman, ladies and gentlemen, I would like to conclude my current management of what I was speaking. Response-guided peg interferon therapy through baseline and on treatment predictor can maximize certain response. Stopping peg interferon therapy according to the on-treatment response, particularly surface antigen level in E-positive patient and S decline in E-negative patient, can allow poor responder to stop or switch to treatment, not need to be suffer from 1 year interferon therapy. Peg interferon and nucleoside combination may be a promising treatment strategy for improving certain of therapy, particularly S antigen loss. However, we still require further study to confirm the results and guide the strategy to the proper way. Regarding the antiviral agent, I will say that if you can use the high potency and high genetic barrier, go for that one first, such as entecavir, tenofovir, because this can give you the very good maintained DNA suppression. However, with the longer treatment duration, patient compliance and adherence therapy is so critical. You need to remind your patient and monitor DNA. We found that from the analog study, 60% of entecavir long-term treatment when they have breakthrough viremia, mainly due to the poor compliance. So you have to use DNA monitoring and confirm and encourage your patient to adhere to treatment and have good compliance. Optimize treatment strategy to baseline factor. You might able to use in low genetic barrier in a country that you cannot afford the high genetic barrier agent, and use DNA response to guide who can continue monotherapy with the low risk of drug resistance. Lastly, due to the high reactivation after stopping antiviral agent therapy, you might use some marker. Currently, we know about surface antigen level to predict who's going to achieve off therapy certain response. My current practice, those who have the antigen level below 200 IU per ml, is allow me to consider stopping therapy with antiviral agent. And I thank you for your attention.
I would like to postpone the Q&A session at the end of the second speaker. Thank you, Prof. Tira. The organizing committee and academic committee is very ambitious, and we want to extract the knowledge from the speaker as much as we can. So we cram together chronic treatment of hepatitis B and C in one session. I think the time is not sufficient, but we want to learn from you as much as we can. The second speaker is Professor Tawisak. He is the current president of the Thai Association for the Study of Liver, and the president of the 4th ASEAN Perspective in Liver Diseases 2016, and we have agreed with the Thai colleagues to have the 5th ASEAN Perspective in Liver Disease APLD 2018 in Myanmar, together with the Thai Society, together with the Italian Society and ASLD, ESL and Korean Society here in Yangon. And Professor Tira and Professor Tawisak will support that APLD 2018. And we want to combine that APLD 2018 and 5th Myanmar International Meeting. So, we are a little bit behind the schedule, but it should be all right because
Okay.
Professor Devisak, please.
Thank you so much, Professor Kim Mong Win, and also I would like to thank Professor Win Yang and the organizing committee for your invitation to speak today. So I'm going to touch upon the chronic hepatitis C. So I'm going to do my best during my 30-minute presentation. So for chronic hepatitis C, it's going to be very easy, and I think for those of you who come from the Western country, you develop either sofosbuvir or co-formulation sofosbuvir, remdesivir as a souvenir back to your country. My topic going to cover the burden of chronic hepatitis C in our country. So I think we are pretty close to Thailand and Myanmar. Natural history and current available treatment as for 2016 and conclusion. So we are living in about almost 20% of the whole burden of chronic hepatitis C in ASEAN country. There's going to be about 30 to 40 million people carrying hepatitis C in our area. And the phenotype distribution in our area is pretty unique. So as compared with the rest of the world, in Thailand and Myanmar, we are having just only two major genotypes, genotype 3 and 6, and just some 20 to 10 from 20% genotype 1, and mostly 1B. So this is quite unique for this particular region. And you know, in those days during independence era, we are so lucky that we have quite easy to treat genotype 3, which is easy to treat by interferon, but it's not true now today. When you look at the natural history of chronic hepatitis C, this is a natural history. For those who good predictors, like a female getting the infection at a younger age, no fibrosis at the baseline, or no concomitant diseases, so the chance of getting cirrhosis in the next 20 to 30 years would be just about 20%. By contrast, for those who are male or have so many concomitant diseases, this could be up to 70% getting cirrhosis. So this is a burden that we come to bear in the future. So we got disease patients at this point with complication of cirrhosis, hepatocellular carcinoma that you have heard about this morning. So this is the reason that we're going to treat these patients. In the past, we have talked about several factors that may contribute to the progression of the disease that include viral factors, the host factors like age, gender, race, IL-28B phenotype, and also IP10. But now, these days, this factor may be just genotype that may be still worrisome for current available drug, but that would be nothing in the near future with the new generation of the drug. Post-treatment RAF, cirrhosis status, and one more important thing is for the oral drug is the drug-drug interaction. Moreover, in our region, Thailand and Myanmar have genotype 3 predominant, and in fact, there are several studies have shown that genotype 3 is associated more severe liver disease, more rapid progression to cirrhosis, and more complications including cirrhosis, decompensated, and HCC developed in genotype 3 related FC patients. Again, this is another study from France.
genotype 3 also increase the risk of cirrhosis and HCC as well. So there are several studies that confirm the same thing, that genotype 3 this may associate with more fibrosis, more steatosis, and that lead to more disease complications. However, once we can achieve SVR, the SVR is currently is defined as negative RNA at week 12 after start the treatment. So once we achieve SVR, these complications are going to be reduced. So less HCC, less complications of cirrhosis, and this can be true even in the patient with cirrhotic. So in the patient with baseline cirrhosis, for sure, you cannot totally abolish the risk of SCC, but the risk is reduced to much less as compared with those who did not achieve SVR. And this results in quite normal life expectancy in chronic hep C patients if you can treat them before they become cirrhosis. So that comes to the treatment indication now stage, so we would like to eradicate. So now, it's not that suppressing like hepatitis B. So for hep C, we would like to eradicate the virus. So eradication means somewhat like cure. So negative RNA after 12 weeks of stop treatment, that's going to be likely cure. Who should be treated? If you have enough money, everyone who got infected with hep C should be treated. But if you are not so rich, or you in our country, maybe you want to prioritize the patient according to the risk. We're going to talk about that. And in the patient with cirrhosis, that even unmet needs, so we're going to treat them now in order to prevent decompensation and development of